Joining us here this morning, very late in the meeting, and we really appreciate you staying around on Saturday. Thank you. I'd also like to say thank you very much to the American Pain Society for offering us this opportunity. So many of us on the federal government are very impassioned about the work that's going on to address both the opioid crisis and the chronic pain crisis in the country. So we really appreciate the opportunity to talk to you about some of the programs that are happening. What we have for you this morning is 3 separate talks, and we've left time for questions at the end. Dr. Grant Baldwin is for the Centers for Disease Control and Prevention. He's the director of the Division of Unintentional Injury Prevention at the CDC, and he's going to give you a briefing on the CDC opioid guideline prescribing for chronic pain. And then Christine Cichetti is currently with the Office of the Assistant Secretary for Health. She is the Senior Behavioral Health Policy Advisor there, and she is helping us draw up the plans for moving the National Pain Strategy forward. So she'll talk to you a little bit about some programs for addressing the opioid issues and also about where the National Pain Strategy is going. And in the middle of those 2 sessions, those 2 talks, I will be talking to you about the National Pain Strategy, just a brief overview of the history for those of you who aren't that familiar with it, and also the changes that were made through the process of the initial draft, which we talked about last year at this meeting. And an additional piece to the National Pain Strategy, our Federal Research Pain Strategy. So with that, we'll start with Grant.
Thank you, Linda, and thank you, everybody, for sticking around. It's certainly a pleasure to be here today. I wanted to also thank Greg Turman, the APS president, for this invitation. I'm going to talk briefly about how and why we developed the guideline and touch at a very high level on some of the guideline recommendations. But that said, I'm going to spend the bulk of my time talking about CDC's dissemination activities. So earlier in this week, I was in Chicago. I've been traveling a lot this week. I was visiting with the National Safety Council, and the president and CEO of the National Safety Council, Deb Hersman, said 3 words that really resonated with me. So when thinking about engagement and judging the success of ending dissemination, she said we need to know about reach, touch, and action. Unknowingly to her, those actually serve as a perfect rubric for what we're trying to accomplish with our implementation work with the CDC guidelines. So what diverse distribution channels are we using to get the widest possible availability for the guideline, the reach? What products and resources are we developing to make it easy for providers and health systems to pick up and understand the guideline, the touch? And what strategies are we implementing to make it easier for providers to deliver guideline concordant care in their offices and for that matter, for CDC to evaluate if the recommendations are being followed, the action? Let me begin, though, by putting CDC's work in prescription drug overdose prevention into a little bit of a context. At CDC, we aim to complement the work of our sister agencies within the Department of Health and Human Services, like NIH, and focus on priority niche activities for CDC. So we have 3 priorities, and they are to improve data quality and track trends to monitor the epidemic, to strengthen state efforts by scaling up effective public health interventions. We have a very large state cooperative agreement program. And finally, to enhance patient safety by supplying healthcare providers with data, tools, and guidance for evidence-based decision-making. Obviously, this is where the guidelines fit squarely. So more than 165,000 people have died, unfortunately, from overdoses involving prescription opioids in the last 15 years. Overall, drug overdose death rates have never been higher, and 6 out of 10 of these deaths involve opioids. Deaths related to natural and semi-synthetic opioids, which include the most commonly prescribed opioids, oxycodone and hydrocodone, the purple line, continue to be involved in more overdose deaths than any other opioid type. But that said, the heroin-related death rates shown here with the orange line have increased 3.5-fold since 2010, and over 10,500 Americans died from heroin in 2014 alone. We've also seen a recent spike in deaths from synthetic opioids like illicit fentanyl, the dark blue line, Heroin may be cut with fentanyl, with or without a user's knowledge, in order to increase its effect. And there was an 80% increase in deaths in 2014 alone. And the reason I wanted to show this slide to you is because we recently got some new DEA data, and this trend is going to worsen and worsen quite dramatically. So some background on why we developed the guideline, and this information is likely well known to you. So many Americans, 11% by one estimate from the National Health Interview Survey in 2012, experience daily chronic pain. And beginning in the late 90s, opioids were significantly prescribed or increasingly prescribed for chronic pain, and opioid-related deaths rose in lockstep with this increased prescribing. All the while, the amount of pain that Americans report remains unchanged during that time period. Primary care providers account for approximately 50% of opioid pain medications dispensed, and they also report concern about prescribing opioids and patients' risk of addiction. And unlike you, they have insufficient training in opioid prescribing and in pain management. You know better than anyone how difficult and complicated patient-centered, integrated, and multimodal pain management can be with patients in chronic pain. And you know better than anyone if and when opioids make sense and how to monitor patient outcomes in function and quality of life. And many primary care providers, unfortunately, just don't have this awareness. So that's why on March 15th, CDC finalized an opioid prescribing guideline for primary care providers for chronic pain, or pain lasting longer than 3 months outside of active cancer, palliative, and end-of-life care. It was concurrently released in both the Morbidity and Mortality Weekly Report as well as in JAMA. The guideline is not a rule, regulation, or law. The guideline will not deny access to opioid pain medications as an option for pain management. The guideline will also not prohibit physicians from prescribing opioids. The guideline will not take away physician discretion or decision-making or tie your hands. Finally, the guideline will not restrict the dose of opioids a physician is allowed to prescribe or the number of days for a prescription. At its core in our minds, the guideline supports providers in meeting their Hippocratic oath to first do no harm. It also informs clinical decision-making, we think improves communication with patients, and we hope improves patient safety. So to develop the guideline, we followed a transparent and rigorous process using the best available scientific evidence, consulting with experts, and listening to comments from the public and partner organizations. And these steps are shown here on this slide. For the sake of time, I'm not going to walk through in great detail every step, but I will say CDC did an extensive review of 130 of the most relevant and recent scientific studies on the effectiveness and risks of opioids and other pain treatments. This started with CDC updating an AHRQ systematic review, and after we drafted the guideline, we consulted with more than 50 experts in opioid prescribing, addiction, treatment of substance use disorders, and pain management. And ultimately, the guideline also went through independent peer review. Next, we opened the docket on regulations.gov for 30 days of public comment, and CDC received more than 4,350 comments, the most ever on a guideline released by CDC, from patients, physicians, pharmacists, and 160-plus professional organizations who wanted to weigh in. And finally, we convened our Board of Scientific Counselors for further review and scrutiny. APS or APS members were involved in every critical step of the guideline development. For example, you or your membership were on the core expert group, the stakeholder review group, a peer reviewer, one of 3. You submitted a letter during public comment and represented APS interest during the Federal Advisory Committee review. We found everybody's input helpful, including those provided by APS. These guidelines are not a panacea for either our country's opioid problem or our pain problem. It's one step, and we believe an important step, to more cautious prescribing of opioids among primary care providers while ensuring patients with chronic pain receive safer and more effective pain management. Up to 1/4 of patients receiving prescription opioids long-term struggle with addiction, and nearly 2 million Americans abuse or were dependent on opioids in 2014. Primary care providers are concerned about opioid addiction and report insufficient training, as I mentioned earlier. At the center of the guideline is a reevaluation of what we've been told about opioids for chronic pain in light of what we know now. We believe it's a common sense approach to prescribing that updates how we should use opioids for chronic pain in light of their uncertain benefits, but increasingly known and serious risks. Among the 12 recommendations in the guideline, 3 principles are key to improving patient care. And they are: first, non-opioid therapy excuse me, should be preferred for chronic pain outside of end-of-life care. When opioids are used, the lowest possible effective dosage should be prescribed to reduce the risks of opioid use disorder and overdose. And third, providers should exercise caution when prescribing opioids and monitor all patients closely using PDMPs and other means. So we created clinical reminders or prompts that correspond to each of the 12 recommendations to make it easier for providers to follow the guidelines. For example, a provider should establish and measure goals for pain and function, use urine drug testing to identify undisclosed use, and avoid co-prescribing of opioids with a benzodiazepine like Xanax or Valium. To be sure, there is a need to do more research and continue to build the evidence base on opioid benefits and risks, along with the effectiveness of other pain treatments. We consistently heard this feedback, including from APS, and we agree. In the meantime, we need to start with the evidence we have and act given the urgency of the problem, and that's what we believe the CDC guidelines do. So we worked tirelessly to get make sure we got the guidelines right. However, really the success, in my mind, of the guidelines really does hinge on how effective we disseminate them. So we've identified 4 priority areas to maximize uptake and use, and this includes developing communication and translation materials to make the guidelines more accessible, educating providers both when they are first trained or through ongoing continuing medical education, working with health systems to integrate guidelines into clinical decision support tools and practice protocols, and finally to leverage insurance or pharmacy benefit manager schemes like proactive use of claims information and drug utilization and review. Of course, improving insurance availability and coverage for non-pharmacological treatments is important too, and we're working on that. Throughout the development of the guideline, and now that it's released, CDC worked closely with our federal partners like NIDA, the CMS, SAMHSA, and FDA to make sure that it will be used. We're also collaborating with prominent medical societies, including APS and others, to do the same. So far, the guideline has been viewed, and this is data as of a couple of weeks ago, 375,000 times, and downloaded, and this is just the full text guideline, 32,000 times. And there were about 750 news articles about the guidelines in the days following the release. So we were understandably very, very pleased with that. On our dissemination efforts, many of you are familiar with Atul Gawande, the surgeon, writer, and public health researcher. He's most well known for the Checklist Manifesto. We worked with Dr. Gawande and his team to create this easy-to-follow checklist or algorithm about the CDC guideline. It's a pocket-sized checklist, and we think it'll make it easier for providers to follow recommendations at the point of care. Here's an example of a fact sheet we developed. It's about prescription drug monitoring programs, and it guides providers on when they should check the PDMP and highlights things they need to consider when prescribing opioids, like patients being on a high daily dose or being seen by multiple providers and receiving opioids. We also have fact sheets on a number of other topics, including creating or calculating total daily dose of opioids for safer opioid prescribing and pregnancy and opioid pain medications. So in the near future, we'll be releasing a mobile app that will include a morphine milligram equivalent conversion for some of the most commonly prescribed opioids, as well as tips for providers to use when initiating conversations with patients. We also have a pocket-sized guide coming up on tapering and some materials co-branded with the Surgeon General's office, given his interest in this issue too. And I think we talked yesterday at the Education Special Interest Group about other opportunities for CDC to collaborate with organizations like APS on other materials. So within education and training, CDC is creating training modules on the guideline and will offer clinicians continuing medical educations to complete the training. For example, CDC is planning a series of 6 one-hour webinars where CMEs will be offered about guideline-relevant materials, and we're working with the Center of Excellence in Pain Education at the University of Washington to develop these. They'll be delivered via the CDC Clinical Outreach and Communication Activity, or COCA network, beginning in the June timeframe. We're also in the process of developing a separate 8 to 10 hour online curriculum. And again, at that education special interest group meeting last night, we talked a lot about other opportunities to plug APS membership into those pain education activities. In addition, many health professionals, so schools, have committed to integrating the guidelines into their curricula. To date, more than 60 medical schools, more than 190 nursing schools have announced that beginning in the fall of this year, that they will require prescriber education in line with the CDC guideline in order to graduate. And more than 50 colleges and schools of pharmacy will educate their students about how to counsel patients and others about appropriate use of naloxone. So healthcare systems also have the potential to improve pain management, including safer use of opioids through guideline concordant care, we think on a very, very broad scale. And so CDC activities to assist health systems in this, do work in this area include creating a clinical quality improvement technical package to help health systems develop processes and deploy strategies to facilitate adoption and use of specific recommendations. This includes identifying organizational champions and mechanisms to provide auditing or feedback cycles, updating clinical decision supports to integrate recommendations into electronic health records. For example, alerts on MMEs, defaults on prescribing amounts for initiation of opioids, and prompts to check the PDMP. And replicating the use of care plans to coordinate patients' care and promote best, most effective, and safest treatment. We're trying to stand up coordinated care plans. We're adapting some work that's been done out of Group Health in Seattle, as well as the VA, to help structure and coordinate care long term. And finally, private and public insurers and pharmacy benefit managers can foster guideline implementation through improvement of coverage and service delivery payment models and proactive use of claims information. Priority interventions that we think can facilitate guideline implementation include coverage for non-pharmacologic treatments such as exercise therapy and cognitive behavioral therapy, massage, acupuncture, reimbursement for pain management, including patient counseling, coordination of care, and review of PDMP data. We've got a number of ongoing conversations at CDC with CMS and some of the large private insurers to begin this dialogue. We've been collaborating with Linda and her team as well in this space. And to support guideline concordant opioid stewardship through mechanisms such as drug utilization review. And finally, we believe it's critical to implement payment models that improve access to interdisciplinary multimodal care. So wrapping up, and I wanted to step back a bit and put what CDC's work into a little bit of a context. So our work really closely aligns within the broader HHS Secretary's initiative aimed at reducing prescription opioid and heroin-related overdoses, death, and dependence. It includes 3 priority strategies, including the first one focused on provider training and education. The second one focuses on increased access and use of naloxone, and the third one is about expanding access to medication-assisted treatments such as bupe and methadone in combination with counseling and other behavioral therapies to treat substance use disorders. And we thought President Obama's participation in the recent RX Summit in Atlanta at the end of March was really a great marker of his commitment. And as a way of transition into Linda and Christine, soon after CDC released the opioid prescribing guideline, the NIH Interagency Pain Research Coordinating Committee released the National Pain Strategy. And I'll let Linda and Christine sort of highlight the milestone contributions of the NPS and the Federal Pain Research Strategy. But I wanted to end here because we view the NPS and the guideline as complementary and mutually reinforcing. Chronic pain remains a public health challenge, and people in pain deserve effective, accessible, integrated, and multimodal therapeutic options that reduce their pain and improves their function and quality of life in the long term, and to do so while at the same time assuring patient safety. CDC and NIH and others and within HHS are collaborating to make this all possible. So let me close there, and I look forward to the discussion that follows. Thank you very much.
Thank you. I would like to say in opening that there's a big thank you that goes out from many of us to the partnership between Pfizer and the American Pain Society for their request for proposals targeted to the National Pain Strategy objectives. This is a huge starting point for us. And my role in the National Pain Strategy was as the co-chair with Sean Mackey from Stanford. I don't think I introduced myself, but I'm Linda Porter. I work with the NINDS Office of Pain Policy. I think I'm familiar with most folks here. And so what I would like to start off with is to really underscore the importance of the National Pain Strategy's contribution to addressing the issues associated with opioids and non-prescription drug problems, in that if there is a better system of care provided for people with pain, that's just the entire underpinning of how we need to move forward to address the issues, both crises. I start here with a slide that really addresses the two sides of the issue, that we need to be careful to address the risks associated with opioids. We also need to be careful that people with pain get the appropriate care. And so the president, the quote at the bottom here, and I will read this out because can't see the screen down there, is he really addresses the fact that these potent medications have great potential for relieving suffering, but they also have great potential for abuse, and calls out for a policy that strikes a balance between our desire to minimize the abuse of prescription drugs and the need to assure access for their legitimate use. So the chronic pain problem is enormous. And Grant gave you a little bit of statistics on it. The IOM report noted that 100 million American adults report chronic pain. 25 million people report pain on a daily basis, and up to around 6 million people report pain that interferes with really important quality of life issues. They can't work, they don't attend social activities, they may not get to church, and they pull away from family and friends. We spend as a nation up to $635 billion a year on lost productivity and healthcare related to pain management. And we really don't even have an idea yet, we don't have data to support the notion of how many people don't have access to quality care. We know there are vulnerable populations that have very little access to appropriate care, but overall, there are clearly issues with ability to get multidisciplinary appropriate care, especially for complex pain conditions. We don't know the magnitude of that problem yet. We suspect it's quite large. So the National Pain Strategy, for those who are a little bit unfamiliar with it, evolved from the intersection of two pieces of the Affordable Care Act. One was the establishment of the Interagency Pain Research Coordinating Committee, and the other was the IOM report. The primary recommendation in the IOM report was to put together a nationwide plan that would address prevention, care, education, and research for pain and pain care. And the IPRCC was given that task by the then Assistant Secretary for Health, Dr. Howard Koh, October 2012. We had hoped that that project would be finished in about a year. It took longer. It was a huge project which brought in about 80 experts across the nation. And it was completed, the draft was completed in October of 2014. And at that point, it was cleared by the secretary for public comment. So we put out a period for a month where we took in public comments, looked at them very carefully, and spent several months incorporating those comments into the revised version. That version went back through the government clearance process and underwent some additional changes. We are now at the point where the implementation phase is beginning its coordination. So the IOM report, the National Pain Strategy was set up to align with the IOM report. And so we developed 6 separate working groups along the framework that the IOM suggested. One was a population research work group working under the framework of the IOM that the quantity and quality of care, of data for care, are poor, data for understanding what the population level incidence and prevalences are poor. Several objectives were put together to address that issue. We had a disparities working group that recognized that vulnerable populations receive inadequate and inappropriate care. These clearly are not only vulnerable populations, but they suffer more from disparities. Again, several objectives were addressed in the National Pain Strategy underneath that framework. There was a prevention and care working group, which the framework of which was that accessibility and quality of pain care is inadequate. This is across the board. We had a services and payment work group with the understanding that pain care and prevention aren't adequately addressed by public entities. We had a professional education and training work group who understood that provider skills to treat pain care are inadequate. And finally, but not at all the least important, public education and communication, under the understanding that education programs for patients and the public are really sorely needed. So the pain strategy, through the public comment period and the federal government clearance period, underwent several changes. And I think as you read through the draft from last year and you read this final edition, the changes may be subtle to the reader, but there were actually some really important pieces that came in. Public comments made it clear to us that the strategy didn't properly address the prevention issues. I think the task force initially was a little worried that the evidence to suggest that some of our pain prevention strategies were effective, they felt that the evidence wasn't there to really support strong objectives. Well, clearly from the outside that message came through that we missed that, and you will see that prevention is one of the big components of the federal research strategy plan where we're looking at gaps in our research. So we understand that research is needed to move all of these objectives forwards. Some areas have more needs than others. We didn't clearly represent the lifespan of the population that the pain strategy should be addressing, and especially the pediatric population and older adults. So that has been more clearly represented within the pain strategy. That lifespan begins at birth, goes through adolescence, into adulthood, and into older adulthood, and these populations are called out more frequently in individual objectives. The integrated health care providers were not specifically or as specifically listed as being relevant to pain care as they should have been. We hope this has been cleared up in the revised edition. And then we move, so these are mostly from the public comments, but as we move into where the government clearance process was really helpful, and I think this is important especially for the federal stakeholders, but they asked us to really look more carefully at the metrics to evaluate the objectives of the National Pain Strategy. And so those have been beefed up, but clearly as the implementation process goes through, that's a really difficult area to address. And so deliverable by deliverable, those metrics are going to have to be made a little more rigid and stringent, and they will help us understand whether the National Pain Strategy is really helping patients or not. They asked us to put in, rather than deliverables that are going to be short-term, medium-term, long-term, put in some discrete timeframes so that the government agencies who are leading these efforts know when they need to be finished, just to really help keep things on progress, stay on progress. I think one of the most important things is that we identified as a group before the strategy went out, federal stakeholders that would be most likely to be involved in moving forward the different deliverables. Through the process of clearance, we had a lot of agencies add themselves into the National Pain Strategy as stakeholders who wanted to participate. So for us, this was really encouraging that many areas across the government want to be part of moving the pain strategy forward. The strategy, I think, now addresses better the concurrent health crises that the opioid issues have brought up, as well as the chronic pain issues. And so you'll see a little more integration within the strategy of objectives that address those concerns. So what I'd like to do in the time I have left is to tell you about what we look at as the next step to the national pain strategy. The pain strategy, if you look just at the executive summary, says, we realize that research should have been a big part of this strategy, but we are taking that on as a separate effort through the Interagency Pain Research Coordinating Committee. It will be a strategy that looks across all the federal agencies that support pain research to make priority recommendations to enhance the federal pain research agenda. So what this does, it actually fulfills the original mandate in the Affordable Care Act for the IPRCC to identify gaps in our federal pain research portfolio and make sure that we're not being redundant across our spending throughout the federal agencies. It also completes the research recommendation of the IOM, that should have been in the National Pain Strategy. There's a population research group in there, but many areas of research were not included in it. So we spent a lot of time with our federal agencies and with the NIH Pain Consortium setting up an organizational and an operational structure to move this research strategy forward. This looks pretty basic, and to say we spent a year getting here is a little embarrassing, but there are a lot of pieces built in here of how to integrate these different groups, how to share communication across the groups, how to make sure that we come up with a set of priority recommendations for research that go to the federal agencies that are meaningful and will make a difference over the next several years. So the strategy is structured along the lines of the continuum of pain as put out in the National Pain Strategy as recommended by the IOM report. So these are all very closely aligned and interconnected. And it was set up in working groups that will address clearly overlapping and continuous areas, but that cover primarily prevention, acute pain management, transition from acute to chronic pain management, chronic pain and chronic pain management, and disparities. And so the idea is really for these groups to look at research that addresses basic through clinical research, dissemination research, what happens to what patients, why does it happen, so the mechanistic parts of it, and how to manage it, the treatment components. And to give you an idea of the wonderful representation that we have from across the research community, I've listed here the steering committee membership and the work group co-chairs who will be chairing each of the 5 work groups that I just showed you. Wonderful folks so far. It's been there's been so much effort put in. This is all on a volunteer basis. And given the enthusiasm and the expertise, we expect that we will get a very good product. We have a timeline. We hope to complete the strategy by early 2017. And the groups are in discussions and moving along. They have a charter, they have a mandate, they have resources that we will provide them with, and we hope that we will be able to stay on track with this. This will be in the final approval through the Interagency Pain Research Coordinating Committee before it goes to the federal agencies who support pain research. So what our hope is for outcomes from this part of the effort is that we will have a set of prioritized recommendations that will enhance our research agenda across the federal government, and that they will give us recommendations on how to approach those high-level priorities, and that they will deal with cross-cutting research recommendations that can be shared across the federal agencies whose missions for pain research and constituents all differ to some extent. And that there is a plan for the future, and by that I mean, how will the research strategy be evaluated after 5 years once it's been put into place? How has our need changed, and how do we address that need? So hopefully by next year, we will have a fairly full report, and we'll be able to come back and tell you more. So with that, I am going to very carefully move my laptop so I don't disconnect again and hand the podium over to Dr. Cichetti.
First, I want to thank Linda for the upgrade to doctor. I'm not a doctor, and I don't play one on television, but I am a policy wonk, so and that's the capacity that I'm in here today. I want to start off first by thanking Linda and her team for the tremendous job they did in developing this report. She, unfortunately, has had the pleasure of having to talk to me a lot over the last few months through the federal clearance process, preparing for this meeting and for developing the federal implementation plan. And I really have been struck by the fact that this seems much more of a labor of love than just another government project. So I want to thank her and the team for that. So I've been in the behavioral health field now for about 25 years. And I'm really pleased to see that there has been real progress in regard to the sort of the neurological underpinnings and advances trying to understand the underlying causes of pain, but also the increasing recognition and acceptance that substance use disorders are a chronic relapsing disease from which people can recover. The MPS and the CDC guideline are helping us to go even further in discerning the nexus between pain and substance use disorders. In fact, both were released at a very critical time in public health, and you've all seen the numbers all week, and you've seen the numbers as Grant presented them earlier. And as many of you know from your own experiences and from a lot of the presentations this week, opioid overprescribing and misuse contribute to a growing number of opioid use disorders, overdose, and death. The nearly concurrent release, of the MPS with the CDC guideline highlighted one of the key factors contributing to overprescribing, the need for access to quality pain care. Without a system that addresses patients' needs for prevention, assessment, and quality, integrated and patient-centered care, our nation will not succeed in curbing the harms of prescription illicit drugs to address pain. The objectives of the MPS align with other federal strategies to reduce the potential for opioid abuse, in that they call for provider education, on prescribing practices, pain and pain management, patient education on safer use of opioids, population data, to assess effects of policies on prescribing and treatment practices, and especially important, they call for research on non-opioid pain management strategies that will inform clinical practice and improved access to quality pain care. As Dr. Baldwin mentioned in his presentation, last year, Secretary Burwell announced an HHS-wide, sure I use the right thing here. Oh, there we go. Oh, we're not there yet, okay. Mentioned an HHS-wide opioid initiative. And although the MPS was already well underway by then, and the CDC guideline and the MPS align perfectly with the initiative's goals. And I know that you're all here to learn more about the MPS implementation plan, but there are a few things I wanted to mention in order to highlight how other important federal efforts support the MPS and as well as the CDC guideline. And I hope that you'll consider these efforts to help support your own important work in the area of pain management. There, now we get to slide 2. So, as all of you know, the data and sometimes the lack thereof, which I heard an awful lot about this week, can significantly influence the approaches we take to policy, programming, and budget. I'm sure you've seen a lot of data all week long, but I think a few things are worth reiterating. Although these numbers are not all specific to prescription drug use and misuse, they are indicative of the significant role behavioral health plays in regard to overall wellness. Over the past 3 days, I have heard many presentations that highlight the importance of the impact depression and anxiety have on pain, either as a contributor or as a result of chronic pain. I have learned much about catastrophizing, which I can't pronounce, and have been very pleased to hear that many of you are employing cognitive behavioral interventions to complement pain management strategies for your patients. So these are just the numbers. I'm just going to go through these really quickly. You can see that pain relievers are way, way up there, second only to marijuana. One of the other concerns is there are a lot of other significant public health issues that result from opioid use and disorders, but substantial progress has also been made to reduce the number of HIV infection attributable to intravenous drug use. Such infections fell from 5,799 in 2009 to 4,366 in 2013, exceeding the 2015 strategy target of 4,929. Nonetheless, only certain parts of the country have benefited from policies to reduce the exposure of bloodborne infection. For example, in rural southeastern Indiana, intravenous use of prescription oxymorphone caused an HIV outbreak where 191 persons have tested positive since January 2015. This outbreak reminds us of the work that remains and how we need to be thinking very globally about our approaches. So how is HHS addressing chronic pain and opioid use disorders? There's actually a lot going on in this area. As Dr. Baldwin mentioned earlier, the Secretary announced an opioid strategy in March of 2015. This is something that she feels very strongly about, having come from the state of West Virginia, which experiences these issues in a very significant way. And Dr. Baldwin already went through these, so I won't do them again. But what I do want to talk to you a little bit about is some of the activities that are actually going on at the federal level for each one of the objectives in the Secretary's initiative. So you can see those. I don't think I need to really read through those, but you can see that there's actually quite a bit going on, and this is just a really short list. And I would encourage you all to take advantage of these resources because they're out there, they're available, they're free, and there's always new things coming along. The President actually, in a memo that he released a little while ago, tried to reach out to not just to the federal partners, but also to physicians, other medical professionals, organizations, and wanted to put together some goals to accomplish in the next 2, 3, 4 years. And you can see what these are right here, and you can see that they're very much targeted towards, well, you, quite frankly. So I think that there's a real effort at the federal level to pull in, the folks who, quite frankly, are boots on the ground on these issues. This is the second of the Secretary's goals for the opioid initiative, and this is expanding use and distribution of naloxone to treat opioid overdoses. I know that's a little controversial. Some people really accept that, and some people are still a little queasy about it, but at any rate, here are some of the things that are going on. This is the third objective, and these are things that are going on in expanding medicated assisted treatment to reduce opioid use disorders and overdose. And then there's an FDA action plan, which is really more driven towards what's going to go to market. Okay, so I'm getting to the part that you actually want to hear about now, which is after the IOM released their recommendations in 2011, I want to say, Then Assistant Secretary for Health Howard Koh provided valuable guidance and direction for a plan that is now called the National Pain Strategy. And he asked the Interagency Pain Research Coordinating Committee in NIH to develop that plan. So this chart really just shows you kind of how, in the hierarchy of the U.S. Department of Health and Human Services, this kind of comes down. So you have the Secretary, of course, and then you have the Office of the Assistant Secretary for Health, and then below that you have the Deputy Assistant Secretary for Health. That's actually where I work, and it's sort of my boss that's been charged to work with NIH to come up with this federal implementation plan. Okay, so there's been a lot of progress on the MPS objectives, and you can. I'm not going to read through those, but I can certainly give you a chance to take a quick look at them. But they're based on the major goals: population research, professional education, and public education. You'll have to excuse me for a minute. I'm not PowerPoint savvy, and I'm here with two computers, so it's making it even a little bit crazier for me. So several projects, HHS and partners, that support objectives in the MPS are underway. Objectives on high-impact chronic pain have been accepted for inclusion in Healthy People 2020, development of curricula resources to enhance pain and pain care education, core competencies are being developed for health professionals who manage pain, and a training tool for safe opioid use was released. So the MPS, and I believe, Linda, this is what this chart is. The MPS defined high-impact chronic pain as pain associated with substantial participation restrictions in work, social, and self-care activities lasting 6 months or more. So you can see from that table what the screening assessment tool looks like. And the MPS work group developed a screening tool with operational questions to determine the impact on chronic pain. Oops. The goal was to use the definition and tool to determine the prevalence of high-impact chronic pain so that the population-level data subsequently could be collected across the population and from vulnerable populations to determine access to care, costs of care, benefits of care. The questions were validated in a pilot study, and that publication is coming soon. So Dr. Koh asked the MPS include an objective on chronic pain in Healthy People 2020, and you can see from here that that these national health objectives for the nation really do very much play into what we're trying to do in addressing chronic pain and other serious public health issues. There are, I should mention that efforts to include pain-related objectives for Healthy People 2020 and for 2030, which is already in development, were led by Chad Helmick at CDC, who was a representative to the IPRCC. So as you can see, there's 4 developmental objectives for pain. The 4 objectives, assess high-impact chronic pain, were developed by an expert group and approved for Healthy People 2020 by the Healthy People Trans-Agency Coordinating Committee. And the initial focus is on Objective 1, which is decrease the prevalence of adults with high-impact chronic pain. And these require baseline data on high-impact chronic pain prevalence to support that objective. And the data is being collected through pain-relevant questions included in the 2016 and 2017 National Health Interview Surveys. So those are the questions. The questions from the MPS screening tool on high-impact chronic pain were validated by Dr. Von Korf, indicated that it was feasible to collect quality data on prevalence of low, moderate, and high-impact pain. Several questions were developed and cognitively tested through the National Center for Health Survey Cognitive Lab. 2 questions were selected and included in the 2016 and 2017 NHIS. The data from all these questions will support the Healthy People 2020 developmental objectives. The MPS noted that the public health significance of chronic pain and the need for better quality data on prevalence, impact, and treatment outcomes. A series of recent publications focused on use, costs, and coverage of complementary treatment approaches and on how chronic pain affects lifestyle and function, which were published by Dr. Nyhan at NCCIH. Dr. Pitcher, also at NCCIH, provides data on how high-impact pain interacts with other pain-related conditions. For example, sleep and mood, and interferes with the function of quality of life. The examples in the chart compare work days lost for those with pain, chronic pain, high-impact chronic pain, more severe and higher frequency pain clearly has a potent effect on the ability to work, as is the case for many other activities such as school, church, and social events. So I think you've heard about the Centers of Excellence in Pain Education probably quite a few times over the past few days. NIH awarded 12 academic teaching centers to develop case-based learning modules on a broad array of patients with complex pain conditions. The Center for Excellence acts as hubs for the development, evaluation, and distribution of pain management, curriculum resources for medical, dental, nursing, pharmacy, and other schools to enhance and improve how healthcare professionals are taught about pain and its treatment. The core competencies effort was led by Fishman and Young at UC Davis. The objective of this project was to develop core competencies in pain assessment and management for pre-licensure health professional education. Such core pain competencies common to all pre-licensure health professionals have not been previously reported. They serve as a foundation for developing, defining, and revising curricula as a resource for the creation of learning activities across health professions designed to advance care that effectively responds to pain. These have been endorsed by numerous professional societies. Let me ask you, how many in this room have actually heard of this Pathways to Safer Opioid Use? Oh, good. How many of you have actually used it? No, not as many, okay. This is a really wonderful tool that is unwonderfully underutilized. I actually participated in making recommendations for the final revisions to the tool, and as such, I actually completed many of the modules. And it does take a bit of time, but it's really informative, and it raises a number of issues that I am absolutely positive each of you deals with every single day in your practices. And the way that the tool works is it's for physicians, pharmacists, nurses, and patients. And you go in and it asks you a question, and then it kind of leads you to the next, and to the next, and to the next scenario. And it was very well thought through, and it's not just it doesn't just give you standard scenarios necessarily, but I highly encourage you to not just do the modules that are specific to your own profession, but to check out the other ones as well, to kind of see what's going on in the mind of the patient, what's going on in the mind of the pharmacist or the nurse or the physician. So, now we get to the implementation of the National Pain Strategy. I will say we're in the really early stages of this, so what I'm telling you about today is really sort of our initial thinking, but how we're thinking about this is actually based on a structure that we have used, and that I have used over many, many years. The Department of Health and Human Services has an internal group called the Behavioral Health Coordinating Council, and it's made up of principals of all of our agencies and OPDIVs, and it has 7 or 8 subcommittees that work off of an agenda that is set at the beginning of the year to work on a variety of different projects. We're setting this up very similarly because it works. And the way that that will work is you will have your principals group. So this is the leadership of the department from anyone who has a stake in this process. And they're really kind of the people who will help drive the work, will help us deal with any resource issues, of which I am sure there will be many. And then so that's the principals group, and then there will be a steering committee that will be made up of higher level staff who will really get into sort of the guts of making sure that the work groups and subcommittees are put together, that the work that they're doing is happening, it's moving forward, that if there are any kind of critical issues that need to be addressed, they get taken to the top immediately, so that this thing doesn't just kind of sit around. And it's, it'll be pretty labor intensive, but it works. And as Linda mentioned earlier, when the document went through clearance, we actually had people saying, we want to play. So I don't think we're going to have any trouble getting volunteers for this. And one of the things that we're strongly considering is the Office of the Assistant Secretary for Planning and Evaluation at the department has a tracking system of which you can kind of plug in your strategy or your initiative or whatever it is, and you can really track progress on your objectives, your initiatives, where are you in this process and that, and we think that is really going to help us to understand where we are in each process for accomplishing each of the goals and objectives that are in the strategy, where are we being held up a little bit, and also, of course, will help us track, where we have really made progress. And I can assure you, there will be a lot of people here who will be hearing from us as we really start to kind of develop our strategy for moving forward. So we're also coordinating outreach and dissemination activities that'll be around this, and we're actually working with the Office of the Secretary's Communications Department as well as the OASH coordination, our communications office. So we're going to be talking about materials and information, what are best for our federal and private stakeholders, how are we going to do biannual updates to our external partners. I have no idea what's happening there. Getting feedback and advice, stakeholder commitment, dissemination of the national strategy deliverables. So we see this as an ongoing collaboration. My part of it is sort of the federal implementation, but make no mistake, this will be a collaborative effort for a long time to come. So I want to just thank you for your patience and attentiveness on this final day of what has been a really intense conference. And I know that my colleagues and I are looking forward to working with you over the long haul to really improve pain management and to address the accompanying substance abuse disorder problem as well. So thank you.
So we have time built into the program for questions. If anybody has one and they could walk up to one of 3 standing mics, we'd be happy to do what we can.
Hi, George Commercy from University of New Mexico. We have the dubious distinction of having the second highest rate of prescription opioid overdose in the nation. We've had several really good talks on using buprenorphine for pain relief. In my state, it's easier to get industrial doses of Dilaudid, methadone, or oxycodone than it is to write for buprenorphine for pain. So this comment's addressed to the gentleman from the CDC. If your 4th point of your slides was about working with insurance agencies, if you can make it easier for us to get buprenorphine from our insurance companies for the treatment of pain, I think that would go a long way to increasing opioid safety and reducing drug overdose.
Thank you. I think that's a fantastic point. SAMHSA is the federal agency that sort of governs medication-assisted treatment, and they set, through data 2000, rules that govern, how complicated it is for prescribers to prescribe buprenorphine as medication-assisted treatment. But as Christina said, I think it's part of a larger department-wide initiative to increase access to medication-assisted treatment. CDC's state-based program doesn't directly attend to that, but we have a very large-scale MAT evaluation that we're working on with SAMHSA, given the fact that federal funding is improving on bupe. So I'll leave it at that. But and I didn't have a chance to talk about it, so we have a fairly significant state-based program. We're funding 29 states right now. There's 2 FOAs on the street right now to both expand the number of states, increase surveillance of the problem, and a third one that's to double down on our investment in the highest burden states, including states like New Mexico. I had a chance to talk to Mike Landon, the state epi, last week when he was in town from New Mexico, and I'm very, very energized about getting New Mexico the resources that it needs to attend to the problem.
Yeah, my name is Justin Wasserman. I'm a clinician in Bethesda, Maryland, and I have a very complex patient load. I get most of my referrals from other pain doctors in the whole Mid-Atlantic area, people coming from all over. So I deal with an extremely complicated group of patients who've essentially failed traditional, more first-line pain management groups where they're doing mostly injection-based therapy. So again, what I can say is a couple things. It's obviously an extraordinarily complex problem, and I certainly applaud the CDC for trying to make some effort, a large effort for that matter, to try to address this growing and horrific problem that's really just swept this country. But if I may just add some thoughts on this and a couple suggestions that I feel would benefit. I think one question I'll sort of jump to that the last gentleman pointed out, I think what he was referring to, and I would second that, which is that when you talked about buprenorphine in terms of substance abuse treatment, I would posit that using buprenorphine as the go-to molecule, if one decides that an opioid at all is even necessary, that buprenorphine would be the ideal molecule. And I think more physicians need to understand it because, again, the drug is just inherently more safe than traditional pure mu agonist opioids. And I'm not talking about for addiction treatment. I'm talking about for pain patients who have failed other modalities, who one has decided and deemed has to be on some form of opioid because there simply is no other solution. Now that's number one. Number two, that whole notion, as someone who sees all these different patients that have severe intractable pain, I would say, and I was somewhat addressed by the board up here, that the largest problem, as I see it, is just a clear lack of understanding really what pain is. That's been talked about ad nauseum at this meeting in terms of the psychological aspects. Even the lecture this morning, looking at different brain mechanisms with irritable bowel syndrome and so forth, if anyone happened to attend that, just shows the enormous complexity of the problem. And to simply use opioids in general as kind of a fix-all, which is what people have been doing here for 15 years, not just in primary care, but even in the pain community, is tantamount to finding a simple problem in a whole village, like a plumbing problem throughout, a sewage problem, and then raising the whole village and throwing everything at it to try to solve an inherent problem, because pain itself is so complex. To just throw opiates at it is simply doing all kinds of secondary effects that are unintended. The other thing I would make note of in the last comment that I think the CDC didn't recommend, and this I think was highlighted by a letter that was published in the New England Journal of Medicine a few years ago, where they anonymously asked physicians who treat pain with opioids, you know, why, and again it was anonymous, so they got honest answers, why it is that certain physicians would continue to prescribe opioids to patients that they knew were abusing the drugs. In other words, these are patients that not just were perhaps misleading the doctors, but where the doctors themselves knew it. And they said the number one reason why they did that was because they wanted to maintain good reviews online and to look good in patient review surveys. Yes. And that's a huge problem because I can't tell you, because physicians unfortunately simply don't want to cross their patients where they're going to go there and review them. And I would say that as someone who deals with complex patients, if you're going to be in the line of treating chronic pain, you have to have a thick skin and be able to say no.
Thank you for your comment. I'd like to touch a little bit on the educational piece. I think everybody here agrees with those comments. It's an incredibly complex situation. There are a lot of issues that need to be addressed. Part of it is better pain management. Part of it is accessibility to better pain management, payment for it. But you mentioned provider education, and this is, what many of us felt during the development of the pain strategy was the underpinning. If the providers were better educated of how to really move pain management forward in a productive way. That said, they need the resources to get there, but that's a big part of the strategy. I think the CDC and many of the other agencies across the federal government are working towards prescriber education, provider education on pain management, and pain itself. So good points.
Yeah, I think that's part of what the guideline we hope they would do is sort of invite a broader conversation about appropriate pain care in this country. And we think some of the, I mentioned some of the education and clinical training initiatives that we have ongoing, I think are intended to attend to some of the things that you raised. Lastly, we are working closely with CMS to have those to sort of disentangle patient satisfaction scores from reimbursement and opioids. So those conversations are ongoing. I mentioned yesterday that CMS has identified a point person to govern all opioid strategic decisions within Medicaid and Medicare, and we're going to be meeting with that individual and his team in the next few weeks to move those conversations forward.
Hello, my name is Brent Bavard, and I'm a physician who was previously in Albuquerque, New Mexico, and on Michael Landon's board, and the governor's board for misuse and abuse of opioids, and I think some great things came out of that state. I have since moved from Albuquerque, New Mexico, and now I'm in Hattiesburg, Mississippi. So I'm in another undeserved area. I have been asked to set up a medicinal management pain clinic. No injections. We're not motivated to make money off of persons with pain. It is an extreme challenge. Let me tell you why. In the last year, I have 2 nurse practitioners with me and myself, and we're the largest multi-specialty group in the state of Mississippi. If we see 20 patients a day, and 6 to 8 of those are consults, we're there from 7 a.m. till 6 p.m. This year, we ran in the red by about $250,000, even getting to that point of patient care. We're not reimbursed to do the right thing. We are reimbursed to do injections, and so how long is it going to take to get reimbursed for trying to follow I applaud all the efforts by NIH and CDC, and we're following guidelines, and I love that you're coming out and making this easier for those of us who really want to do the right thing. But unless we're reimbursed for it, you're going to continue to promote, and I've been on both sides of the fence. In Albuquerque, I was in an anesthesia-based pain clinic, which is injection, you know how that goes. Opioids for injections, it's a real problem. Anyways, how long will it take to get the right kind of payment systems so we can practice this type of medicine appropriately? Because we can't. And there's someone in my community, the names won't be said here, but had to start paying patients, had to start charging patients cash to be able to write the opioids because he lost a partner, and he has an interventional practice, and he's a private physician, and he can't support himself unless he does procedures. Because you don't get paid to talk to patients. You don't get paid for cognitive behavioral therapy. You don't get paid for the things that matter. That's the real problem. So there's no incentive for physicians to, unless you're just trying to do the right thing and you're blessed like I am, where the organization is big enough that they are accepting a loss. And hopefully within a few years, we can at least pay for ourselves.
Thank you. Yeah, totally sympathize with your problem. And that is, something that was clearly understood by the experts that put together the National Pain Strategy. If we don't have modalities to offer to patients and we don't have a way for them to have them paid for, then we recognize that the physicians are stuck and that they are able to only provide unimodal modalities, short-term care. So this is a big part of the National Pain Strategy, is to begin to look at how, first of all, the evidence for multidisciplinary care, when it's appropriate, when it's needed, how to move people into pain care specialties, but also the accessibility to care through payment, through better training. So I would like to say, how long is it going to take? These are step-by-steps. I wish I could say next year you'll see a change in how you get reimbursed. I have a feeling it's going to take longer than that, but we are pushing. I mean, we're on your side in that regard in all ways, and the pain strategy, one of the 6 major themes of that was to reconstruct how payment is made to get these out to not just rural areas, but to everybody.
And I think we're doing it, just to add to what Linda said, and I agree with all that we're trying to accomplish. We both sit on a cross-HHS committee right now to look at insurance coverage for non-pharmacologic therapies, to get a better understanding of what state Medicaid programs and private insurers are supporting, given the fact that we just came out with the CDC guideline. And we're also working, we've got some efforts ongoing in other areas within unintentional injury prevention that we're reporting here to develop, I think, to pursue CPT codes around checking PDMP, coordination of care, et cetera. That I think, again, those time horizons for getting CPT codes passed is a couple of years, as I understand it. They can be accelerated, but I think we're very much sensitive to that, and we're pursuing it.
So I'm going to preface my remarks with some comments to these and your comments. 1996, I believe it was, Johns Hopkins University hosted a conference which is now in print in the IASP press called Pain Treatment Centers at a Crossroads. If you've not read it, you should, because you're talking, Dr. Baldwin, about new CPT codes. That's still piecemeal care, okay? And this was talking about the impending demise of multidisciplinary, comprehensive pain management programs for those people that really needed them, that couldn't be managed by a nerve block or some PT or something like that. So that would be useful for you to look at, because I've been around long enough, I'm fearing history is going to repeat itself. So let me get to my comment. I'm Dave Haddix. I'm Vice President of Health Policy for Purdue Pharma. We have 40-plus years of longitudinal, nationally representative data on substance use and mental health disorders from NSDUD. Dr. Baldwin presented 17 years of overdose data involving opioid drug substances. We have TEDS data going back I don't know how long. We have monitoring the future data from 1971, I believe. If you look at the NSDUD detailed tables, that's every year a PDF that's 1,100 plus pages. I'm hearing we're going to have 2 questions about the high impact chronic pain going forward on NHIS. How are we going to look at and analyze all these policy changes that are happening right now, private and public, and make sure there are not unintended consequences on the population that most of us care about if we don't have something comparable to all those other data streams? It seems like it's an asymmetric problem that I don't see a solution for.
Right, thank you. So just to make sure that there's some clarity here, there are many, many questions on chronic pain in the National Health Interview Survey and some of the other large national surveys that go out. These 2 were specifically raised as part of the national pain strategy because of the slight tweaking to the definition for high impact chronic pain, and an attempt to try and get at the population whose pain interferes with their lives in many, many different ways. So the National Health Interview Strategy, Survey rather, as Christine mentioned, there have been a lot of recent publications on pain that has been defined in different ways that picks up interference with life, but not asked in a very specific way that we can build a database in which we can start to then look at not just the prevalence, but also how interventions are effective and what the costs are. So it's fine-tuning the questions that are in there, if you will. There are 2 questions in there now because partly they are 2 new questions. They are restructuring the National Health Interview Survey as of 2018. And so we've been talking with that group about how the pain questions that are currently in there should be reformulated to some extent and put back into the survey. And those include many, many more than the 2 that you've seen. So those were for high impact chronic pain. But point well taken. The population level data is needed to be more defined, more refined, and better adjusted to the needs of how new policies, new treatments, more evidence for treatments are going to be affecting the pain population. So I totally understand the point.
Hi, my question will be addressed to Dr. Baldwin. My name is Eric Shevlin. I'm a medical oncologist and pain medicine specialist. But my concern now is in a somewhat different role. I've been asked to be a consultant to one of the largest healthcare insurance companies in the country concerning their policies on reimbursement and coverage and pharmacy benefits for opioids and other analgesics. And although you emphasize that the CDC guideline is a guideline, not a mandate, I accept that's true de jure, but not de facto. De facto, there will be pressure on clinicians, insurance companies, which you already mentioned, implications for potential litigation liability, regulatory liability in the future. So it's labeled the guideline, but it has greater impact. My concern in my role as in advising the insurance company is this: the relationship between the insurance company and the insured party is at heart a contract. The insured party pays a premium, and in return, the company pays for medically necessary care. The insurance company is not a clinician. It is not permitted by law to practice medicine, and if it pushes too far into stipulating what's covered and what's not, it tiptoes into the practice of medicine and dictating care. There are no data to show that a prescribing pattern of 3 days of opioids versus 7 days of opioids versus 30 days of opioids for the initial opioid prescription, there are no data to show that that improves health outcomes. So when the insurance company receives a prescription for a 30-day prescription for initial care, should we deny it because it's contrary to a guideline? But we haven't seen the patient. We don't know if that's good for that particular patient. How can the company fulfill its contractual duty, not get into the practice of medicine, and recognize that we don't have data showing this approach is better? That's my question.
Yeah, thanks for your question. The guideline is just that, a guideline. I can't comment further on the extent to which insurers and others are interpreted in more than it is intended to be. And I personally believe, and I think the guideline tries to showcase, that those clinical decisions are made at point of care between a doctor and a patient on a case-by-case basis. And the hope and expectation is that the insurance and pharmacy benefit manager infrastructure would support the appropriate clinical decision that's made in sort of at the point of care between a patient and their doctor. So I get your point. I understand that it's something that we have worried about, but we can't sort of extend beyond that with what we put out in the guideline.
Okay, thanks.
So we have time just for the 2 last questions of folks who are standing at the microphones. We're going to go back to the center.
So let me start with just a request. Renee Manwaring, now at Lurie Children's Medical Center. I'm an advanced practice nurse, and I guess I can use the term doctorate because I have a PhD. But when I hear the decision between a doctor and a patient, I get concerned that it's exclusatory language, and you're excluding advanced practice nurses who have been very sensitive to the issue. I love the fact that you said 60 medical schools have signed on and 190 nursing schools have signed on. So I think we have to be careful when there's guidelines like this that we use terms like prescribers when we're talking about prescription medications. We talk about providers in terms of providing pain care, because psychologists, physicians, nurses, advanced practice nurses, we're all involved, and we don't want to keep anybody out.
Yeah, thank you so much. I apologize. My intent obviously was not to be, I meant to say clinician broadly and prescriber broadly, so I apologize for that.
And I just ask that you be sensitive and that when we review these documents, that people are sensitive to that.
And
to
our,
that
all of the
language.
if you look online at cdc.gov/drug overdose, all those documents reflect the clinician language, so my apologies.
So two questions. One of the things that I think is very important, and I always get nervous when we have these great national, it looks great on paper. And it looked great when we said we were going to allow pharmacies to dispose of pain medications. That came out in 2010, and then in 2012 came out the rules. And I still go to my Walgreens, CVS, Target, Walmart. I'm trying to be as inclusive as possible, any place else you go, and there are not places to dispose of these medications. So I'm wondering, where is the funding to encourage destruction? Because we're still going to be prescribing these for acute pain, but we've got to have a better way for the mom to get rid of these meds other than sticking their kid on their hip and walking into a police station with them. And then my second question is, what is the recourse? I am very concerned. I got a letter from the state of Connecticut, and this is not why I left the state of Connecticut, but I got a letter saying I was one of the top prescribers of opioids. I'm a pediatric acute pain management specialist who absolutely writes opioids for kids who have had horrendous trauma and surgeries. Short term, usually less than 7 days, sometimes more than 7 days. How do we keep the slippery slope from happening that I suddenly get labeled as a problem prescriber, or that suddenly I can't continue to be a pain management specialist and take care of these kids with horrendous? How do we make what you've developed, which specifically says chronic, how do we make chronic not be 7 days? Thanks.
To the question on take-back, I think we generally want to see more an expansion of take-back program. Your point's well taken. I think it's critical to happen. Again, the guidelines that CDC developed were for primary care clinicians practicing outside of active cancer, end-of-life, and palliative care. Overreaching or over-interpreting those beyond what the intent was, we hope would not happen. And as I said, those and APS and others have been critical of duration caps. The intent here is not to do that. It's just simply to provide cautionary moments in time where clinicians pause when writing scripts for longer. And so, again, as an advanced practice nurse, every expectation is that you would use your clinical discretion to make clinically appropriate decisions at point of care with those individual patients. And the guideline does not intend to do anything to sort of stop you from having that patient-centered conversation.
Yes, I'm Forrest Tennant, Los Angeles. First off, I'd like to say compliment CDC and the National Pain Strategy and HHS on the great job you've done. I fully support what you've done, and I think they're a great step forward. My comment, however, is that I think we're already seeing one of the unintended consequences of the regulations or the guidelines, and that is the 90 milligram morphine equivalence is being looked at throughout some communities and some states as a ceiling, and therefore they're discharging patients that are above that. And in my office each day now, ever since the guidelines were published, the calls, the crying, the tragedy is just, it's a little unbearable. And so we have created an unintended consequence, which people were somewhat concerned it might happen. Tangential to this is that I can't say as I blame anybody for wanting to have a pain specialist to see patients who are above 90 milligrams of morphine equivalents. That makes sense to me. What doesn't make sense to me is we don't have enough pain specialists. Okay? As a matter of fact, a few years ago, AAPM did a survey showing that only 20% of people who belonged to that organization even carried a prescription pad where they could write a Schedule II opioid. And so I'm an internist and addictionologist by background, so this is no problem to me. But we don't have enough pain specialists who are willing to do medical management And now we have people throughout the country being discharged because of the guidelines. Now, a lot of these people were started on opioids years ago, and everybody's throwing arrows these days, but, 10 or 15 years ago, we didn't have anything but opioids. We didn't have neuropathic agents. We didn't have neurohormones. We didn't have ketamine. We didn't have low-dose naltrexone. Today, very few people are going to have to go above 90 milligrams of morphine equivalents if they're new patients. But we've got this army of patients who are what I call legacy patients. I would like to ask you what you want to do about them, but I'm not going to do that because I don't think you have any more answers than I do. I just think it's a concern that needs to be addressed. But again, I think you're doing a great job, and we've got some problems, but it's a good advance. Anyway, I compliment you, but I also bring a concern to you.
Yeah, thank you for the compliment. I would say that, again, just to reiterate, that the 90 is not meant to be a cap. In fact, Dr. Turman was the one who suggested change to the specific language of that recommendation that we interpreted, that we integrated into the final recommendation to make it clear to clinicians that it was simply at a point where we wanted them to further carefully justify titrating above 90 MME. So that language was added to the recommendation to signal to clinicians, insurers, and everybody else that's not a ceiling, but rather, needs to be carefully justified.
Okay, I'm sorry, we're going to have to call it a meeting, and I thank you. I particularly thank our panel here. Let me just say that there is something we can do to people who say, for example, this is a cap. It says right here it's a cap. One, you can ask them to read the document, and two, that's what we are, right? We're educators about pain, and so we can be very helpful, be advocates for the pain world, and make it very clear what these documents really say, and then including the National Pain Strategy in that. And please do that. And I would just, as I take off my president tag, I would encourage our federal partners to please try and remember that although when I talk to people, they always talk about pain and addiction, really it's pain and addiction, okay? And very few people get addicted to cognitive behavioral therapy. They may become dependent on it, and that may be okay, but they don't get addicted. And so this is a society, this is the Scientific Pain Society in this country. And we are happy to try and turn anecdote into data, but it's really important when we say pain and addiction that we realize that pain management has never been in this society a synonym for opioid therapy. Okay. So thank you again. And I want to thank in particular, with my last chance, Linda Porter for all the work that she's doing about 26 hours a day on behalf of the pain world. And I just thank you. Thank you very much for coming.